So I'm going to present today about a component that you can add to psychiatric assessment and management. Um, so I'm going to speak a bit about a traditional psychiatric assessment, psychophysiologic patterns and their meaning, and then tailoring treatment to match these patterns. So traditional psychiatric assessment includes taking a history, doing a mental status examination by observing the patient in the room, making a formulation based on the above, and making treatments based on the formulation. Unfortunately, we lack biological tests in general to inform biological treatments that we use. And we use spoken words and sometimes some other aspects of assessment to assess psychological processes and inform treatment. So what I'm proposing here is that assessment can be augmented by evaluating psychophysiologic patterns in your patient in the room. So psychophysiologic patterns are a combination of the genetic load and hereditary tendencies a person has, coupled with their attachment history, attachment patterns that result in discernible patterns that you can see across the spectrum of psychiatric disorders. So you can see a spectrum of attachment-related patterns or attachment types across the spectrum of psychiatric disorders. With psychiatric disorders, sometimes they are the psychiatric disorder, sometimes they're independent of the psychiatric disorder, but they have a huge bearing on the treatment processes and outcome of the psychiatric disorder. So that's why I'm proposing that it's a major issue to have an eye on. So these patterns from downstream effects of attachment trauma and interrupted attachments are specific and visible with physical and cognitive responses that are typically outside of the patient's awareness. They don't report these things, but they're observable. It's much the same as an abdominal aneurysm. The person doesn't report that, but you can palpate it and find this pulsatile mass in the abdomen that tells you that it's probably an aneurysm. So the downstream effects of attachment trauma, attachment trauma being interrupted bonds in early life, typically with parental death, illness, mental illness, parental neglect, abuse, anything interrupting the attachments results in fear of closeness and fear of loss of closeness. And when those events happen in life, and typically around, for example, adolescence, when the person's starting to do things independently or going off to university or getting married or having children or losing family members, all these emotions related to early attachments are mobilized, and they manifest with anxiety, which is unconscious to the person in specific formats, and that results in defense patterns, ways that the person has learned to reduce their unconscious anxiety habitually. So these emotions, therefore, are activated in current relationships, transferred from past relationships. We all do this as a standard format of transferring our experiences with others onto the present experience. But in individuals with attachment trauma, the result is unconscious anxiety and defenses, which you can observe yourself. Patterns the person has when these old feelings are triggered by a new attachment potential with you, the caring individual, the health provider. So to activate these feelings, just being a concerned person will do it, but also focusing in on the person's patterns of emotions and patterns of behavior, how they treat themselves, what they're doing with regards to their health, activates these feelings, which in turn activates the anxiety and defenses. So then you can evaluate the patterns the person has, and that can inform your care. So these patterns, I'll just describe them. Typically I'd show videos, but these are broadcast, so I can't show patient videos in this format. But first pattern is voluntary muscle anxiety. It goes from the top of the body downward, starting with the thumbs, hands, and then it goes to the chest, abdomen, legs, and feet. So what you see is typically in a seated person is hand clenching and sighing respirations, and the person can have spasms, tics, tremors, panic from hyperventilation, chronic pain, fibromyalgia related to muscle tension, that chronic. This type of pattern goes with the capacity to isolate affect or intellectualize or ruminate and use typical character defenses like going passive, compliant, or defiant. So this here is sort of a more solid pattern where the person is tense and defending. but often has muscle-related somatic patterns that you can observe in the interview. The next is involuntary muscle affecting the airway, gut, and blood vessels, typically in the bladder. And you see these are common internal medicine problems with irritable bowel syndrome, migraine, blood pressure problems, bladder problems. This is seen when the emotions are being repressed. So the emotions don't reach consciousness, but instead they turn into a body symptom. For example, the teacher criticizes the student at classroom and they immediately get diarrhea. They don't have awareness of feelings. They don't have awareness that it's triggering some feelings about being criticized and rejected at home. They just get sick in the stomach. The third pattern is motor conversion with muscle. By this I mean specifically muscle weakness or paralysis. This is also seen with repression of emotions. There's specific brain regions involved with this process of repression. These regions are overactive, and this gets corrected when you provide treatments like the one we do here. And there's some imaging studies to support that. The fourth is cognitive perceptual disruption, where the person is confused. They can have sensory distortion, pseudo-seizures, dissociation, and they can have hallucinations. So they can have hallucinations in any of the senses as a byproduct of anxiety. This is seen with what we call primitive defenses, where the person projects their own feeling onto you. For example, thinks that you're angry at them before they even meet you. They're afraid of you. Or using other patterns like splitting into all black or all white. Major problems tolerating anxiety and tolerating ambivalence. So to do this kind of assessment, though, it needs certain things from us. It needs us to be engaged with the person, with eye contact, trying to form a therapeutic attachment, even in a consult, to focus into the problem areas and look at the responses the person has in those when they talk about the incidences. The other things are more like what not to do, is not being overly avoiding the patient, not controlling the interview, not being one up over the patient, not being one down from the patient, not suppressing your own responses to the patient. So being engaged and not avoiding your own internal responses and using those to understand the patient's response and to see how they respond to a concerned person. Okay. So what does this do? It activates those feelings and memories, basically limbic regions with hippocampus, amygdala, and other areas, which activates the anxiety and defenses. Allows you to see if the anxiety and defenses are contributing to the psychiatric presentation, whether they are the entirety of the psychiatric presentation, or whether they are independent processes that are happening and independent of the psychiatric problems at all. So all these patterns they can be seen with severe mental disorder presentations. So this is like a sort of another axis, if you like, the attachment and psychophysiologic axis of assessment. So now if you think about it as far as all the severe mental disorders, they have common areas of brain dysfunction. So these are two based on a large review done in 2015. Two of the main areas here are the right anterior insula, which is involved in sensation of emotions in the body. The dorsal ACC is involved with emotion processing, and the amygdala and hippocampus involved with memory and emotions as well. So these areas are deficits across patients with severe mental disorders. And also the same deficits exist in people with PTSD and childhood maltreatment. So you have a confluence of different processes involved resulting in brain dysfunction, resulting in emotional dysfunction. And then the question is what parts of this can be treated with what type of approaches that we have within our biopsychosocial armamentarium. So here are the different patterns that you can see here, that I'll just describe here. So I'm going to go with I'm going to actually start on the other end. So the low resistant individual is a person who is really very healthy as far as attachment trauma. They've had maybe a loss at age 10. His parent died at age 10. They have some grief about this. They don't have any anger and guilt buried within themselves. They have good attachments. They are securely attached, and are very rare for us to see. And if a person has this kind of pattern and also has other type of severe mental illness, they do well. relatively well. They're easy to work with. They work well with people. They don't have tendency toward any self-destructive behavior patterns. They aren't overly avoidant. But it's also really quite rare to see someone who's low resistant in mental health services. Moving further over here, the moderate and highly resistant group, they have a lot of muscle tension and defenses that interrupt the treatment relationship. So they become quite tense, and they can have some of those physical tension symptoms. They've had trauma that's earlier on in life, and the trauma is usually being emotionally controlled or physically controlled by or neglected by parents typically or others, and results in a tendency to really be avoidant and to have more of avoidant attachment patterns. So these groups all primarily have voluntary muscle tension. The next group here has repression, and so they have, again, at some level of rise in feelings, get the smooth muscle anxiety, become weak, or go to a major depressive process, really exhausted and fatigued and shut down. The next three groups here are this fragile group who have cognitive perceptual disruption and primitive defenses at some level of rise in feeling. The mildly fragile person, they can have some muscle tension, some repression, and then at higher levels of anxiety get confusion and also get these projective processes. So under stress, they lose their vision and they can faint under a severe situation. Going over here to the other end, the severely fragile group, all day long they're in cognitive disruption or projection or splitting. This is a typical severe person with severe borderline disorder features, dissociative disorders, and there's sort of a spectrum, a continuum between these groups here. So there's a big difference between this person here, who has major dissociative component. They can't intellectualize very well. They have real problems recognizing emotions. And they have all these neurological phenomena, losing the vision and hearing and such, versus a person who has more this exhausted repression process, versus a person who is more in this category of this moderate resistant. These are very different patterns of response, and they should be treated differently regardless of whatever psychiatric presentation they come with. So now I mentioned about these attachment patterns. So secure, this group here, the low and even some of the moderate resistant tend to be securely attached versus avoidant attachment here and disorganized attachment here. Talking infantile trauma here from early attachment process problems here, and then it gets trauma, the bulk of the trauma is later as you go across this spectrum here. Percent of outpatient psychiatry referrals, this is a study I did on outpatient in an outpatient practice, a private office. There was a quarter of them had this fragility, a quarter were high resistant with this repression, 35% had repression, high resistance, and you see only 1% had low resistance, just really rare for us to see. Treatment length using the intensive short-term dynamic psychotherapy model is just 1 or 2 sessions here. Moderate resistance about 10, high resistance can be 20 to 40. Repression is the same. And the fragile group is no longer short-term therapy anymore, although they can benefit from 20 sessions. But in the ideal world, they would have a few years of treatment. So thinking again about how they present diagnostically, I think I've kind of covered this. But the low-resistant patient, very receptive to work. And the consult can cure the grief they have. It's like 1 session. The moderate resistant person, they have, if they have a depression, it's really a ruminative depression. They're just worrying and ruminating and quite tense, and they have muscle symptoms. They can have some like cluster C personality problems. With them, if you just stay present with them and assist them to recognize and feel the emotions they're having coming up with you around the attachment process with you, that is the main bulk of the treatment, and I'll describe this treatment a bit more in a minute. The high resistant group, though, on the other hand, though, is very detached, habitually distancing, have provocative defenses that keep people away, and they tend to self-sabotage habitually. presenting with things like GAD, dysthymia, all have personality disorder of some type. They can have like a refractory, ruminative, very tough to treat depressive process. They can have all kinds of refractory tension-related somatic symptoms, chronic pain. They have major problem recognizing emotions. So with this group, treatment involves helping them recognize how the detachment is working in the room and help them stop going detached. It's harder work there. The third, this repression group I described, but with those groups, they need capacity to isolate affect, to be able to observe their body responses, to be able to tolerate anxiety, and then gradually their underlying attachment feelings come up in treatment. So first is building that reflective capacity. They, by the way, can present with a classic major depressive process with exhaustion and shutdown. And they have this very tired body, chronic irritable bowel, chronic migraine, as well as these other, some hypertension and bladder spasm. And they can also have conversion. So the fragile group, as I mentioned, they can have present with psychotic episodes that are transient typically. They can present with depression with psychotic features, severe anxiety, and they all have functional neurological somatic disorders by definition. So they mostly see neurologists, mostly had MRIs, and they also have this repressive process. So they can have this exhausted, confused process, bunch of symptoms. And treatment is similar to the above. Well, I'll describe that a bit more in a minute. There's another process that these patients have, which is self-escalation in these fragility and in some patients with psychosis. And this is something that we cue into, and it seems to be a very helpful process. It's primarily a reflective cognitive process that we're doing. It's around cognitive awareness of emotional patterns here. So here's how it goes. So the person starts off with fear of being attacked or punished. Say, we'll start the cycle here. Then that causes them to have rage towards the person that they fear is going to attack or punish them, and that could be you. But then the rage gets repressed with guilt. So the rage goes in on themselves. When it gets repressed, it turns into more projection that they will be punished for their rage. Okay? Then that causes more fear of the punishment, more rage toward the punisher, more guilt about the rage, and the cycle goes around and around and around. So what's the missing element here? You can say the missing element is just that they don't recognize the cycle that they're in. But another way to say it is that they don't realize that they have mixed feelings. They don't realize that there's a process that they have guilt about anger towards people, that they shut down themselves because of not wanting to harm anybody. And then that causes this repression and projection. So I have fascinating videos where you help the person see this, and it completely interrupts that process, and it makes the anxiety go into the muscles. So they're reflecting better, and they're holding anxiety in the muscles. And when they hold it in the muscles, they stop holding it in the form of cognitive disruption at that point in time. You basically break the cycle. So it seems to be acutely helpful for patients to recognize these types of cycles. So thinking about it now and relating it to severe mental disorders. I mentioned that these phenomena can be the severe mental disorder. They can coexist with these disorders. And I'll give for example, you can see moderate resistance in a stabilized person with schizophrenia or bipolar disorder. I've seen them. I worked with early psychosis in the past, and we've seen some of these people who are stabilized, and they have more like a moderate resistant pattern. And they do well typically. They relate well to the treating staff, their doctors, their families. They have support, and they tend to do well with their treatments. Keep functioning typically too. The other thing though is that these conditions, these psychophysiologic patterns, can mimic severe mental disorders as well. So fragility can look like, this fragile group can look like every psychiatric diagnosis, and they can have every psychiatric diagnosis. They can go from look like they have bipolar disorder, they can have psychotic moments, they can go through eating disorders, severe anxiety disorders, substance problems, and basically move between different patterns over time. But these are all kind of treatable in the package of building capacities with these patients. So the other thing that can happen with these patterns is they make the person treatment resistant in some cases, and they can interrupt the treatment relationship. So if the person, say, is overly defended or provocative, I mean, it makes it difficult for the treater to want to work with the person because they're finding it provocative and annoying. And if the person constantly is in a self-defeating habits and patterns that are there, it also gets difficult for the treaters as to what they're going to do with it. The other is just a patient who's so detached and distant that you can't really get to know the person and be of a therapeutic assistance to them as a provider, as a doctor, or a psychiatrist, or health professional. Another element here is that these patterns, these psychophysiologic problems here, they can block aspects of recovery. So, for example, we all know that our patients over time sometimes have terrible experiences and become incarcerated, have to be brought into treatment against their will, brought by the police. They have adverse events from the illness. On top of childhood adverse events, they end up with illness-related adverse events that they cannot recover from until they work through the feelings attached to that. So that's another aspect, is that unaddressed emotions can perpetuate relapse risk and non-recovery in these individuals. So here's a couple of examples of patterns that are not compatible with just a psychophysiologic cause. So one was a person, 60-year-old with treatment-refractory major depression, also had an autoimmune syndrome, stable on treatment. 17 sessions of treatment targeted primarily for treatment-resistant major depression. The mood improved and now able to identify her own emotions, but she kept having this low energy problem, this fatigue. And by all markers that we were seeing, she should have had a lift of her overall energy and mood. And her mood did improve, but her body was still tired. And we just figured it must just be because of the autoimmune condition. But then in follow-up, we found out the person had a cancer that was latent, and it was just percolating along over those months. So this was one thing to think about is if the signals of these patterns don't fit, then consider other factors. Consider biological or other factors outside of psychophysiologic causes. In other words, you should see sort of a cohesive picture if what you're treating should clean up or deal with those type of problems. If it's not, then it means there's some other causative factors that are probably there to have a look for. Here's another example, a person presented with mental confusion. Also, her anxiety was in muscle tension. She was well able to identify her own emotions. So she showed good anxiety tolerance, but she was still having this confusion. And we referred her back to medicine and asked them to evaluate what was going on because it just didn't fit. The pattern didn't fit. And come to find out that she had been on Plaquenil and had Plaquenil toxicity. Neurotoxic effect, and the problem's all resolved when they stop the Plaquenil. So if we think about these patterns then, what interventions help? And I'm thinking here biopsychosocially of the aspect of this condition that is related to the attachment trauma. And again, these all can be independent of or with a severe mental illness, or it can be the mental illness. Okay, you got to figure out which is which. So first, the low resistant patient, you're almost never going to see them. Help them feel the grief. They don't need anything else. They're well supported. There's no medication requirement at all. Now the moderate resistant person has muscle tension related phenomenon. From the biological side, you could try benzodiazepine if you wanted to, but then you're going to have to keep it on there because they'll get tense as anything when you try to reduce it. There's problems with pain medications because, again, it reduces muscle tension, and it's difficult for them to benefit from them. They get a temporary effect. It's more problems than anything. Antidepressants tend to make these patients more tense and more agitated and more sometimes like akathisia. And restlessness to the point it can increase suicidal ideation in the people who start off with baseline high levels of tension. And antipsychotics have the same effect. Now the question you could say is, well, why would we do medications anyway? Well, we have to have enough therapists around and access to therapists to provide therapy. Now, if you have therapy, these are good responders to multiple kinds of psychotherapy, focusing on emotions, focusing on thoughts, focusing on avoidant behaviors, focusing on relational patterns. So there's your interpersonal therapy, your cognitive behavioral therapy, treatments like intensive short-term dynamic and psychotherapy, emotion-focused therapy. These can all bring up the attachment feelings. They bring them forward to be examined and processed in the room with the therapist. So they bring these things forward naturally in the setting of general therapeutic skills and a focused process. They do well overall. But again, they're only 10% of outpatient referrals, but they do well. So as far as social familial, they have good supports generally. You don't need to sort of do much as far as social familial issues here. But it can help if they have a loved one who really tries to get them to be present and have a loving relationship with them. That helps a lot here. Okay? So, I mean, you could say, who doesn't that help with? Well, these patients don't need that because they already have it. These individuals here tend to detach. A high-resistant group, it's the same issues with medications here because, again, a lot of muscle tension. They are refractory to medication and standard therapies. They tend to undermine the therapist. And the work needs to focus on how they avoid closeness and being present in the room with the therapist. And that work then mobilizes the past unresolved attachment feelings. Now, if you do therapy that doesn't zero in on emotions, rather zeroes in on behavior patterns or relational patterns, these feelings are going to get triggered in the room towards the therapist. Then the question is, what are you going to do about that? If we deal with those, then they get the benefit of dealing with some of these old attachment trauma. If not, the person tends to go to treatment resistance. So they tend to worsen or stagnate in treatment. So they look like they're getting better, then all of a sudden they're tensing and detaching and getting more back towards self-sabotage, and all those feelings are trying to trigger towards the therapist. We got to help them with that. And then that can overcome that resistance and help the person move on. Now, on the social level, this high-resistant group sometimes they're really hermits and very isolated. So any kind of socialization can help them. And what I mean by that is, groups, social, encouraging them in some ways to do social things, to get the exposure to other people who want to know them and are concerned about them. That activates those old emotions. That helps you in the therapy process too. So, okay. Now this repression group, there's no real role for benzodiazepines here. Now antidepressants can be quite effective for symptom reduction here. And also antipsychotics could actually work here too. They work on a behavioral level, on a psychophysiologic level, by making the anxiety go into the muscles. They get more solid and tense instead of flat and weak and exhausted. So they're more toned up. ECT can certainly be effective here as well. There's going to be a lot of relapse if you're going to use these treatments. And I mean relapse from the perspective of repression from attachment trauma. Okay? So an emotionally driven repression process. From the treatment perspective of psychotherapy, there's a part where you build capacity through self-reflective processes, and there's treatment packages that do that. And here's, like, for example, day hospital program has a lot of these elements built in. DBT has this, EFT, standard CBT. Our treatment too has a first phase, building capacity. The next phase is the emotions from the past start to break through, and they start going through attachment trauma related feelings. So you want to help them with that part, a second part that comes after you build capacity. If we don't help them deal with those feelings, they tend to regress again, and they can go worse, and they can flip into substance problems or some other kind of self-injurious pattern. So these treatments above, however, all can reduce relapse risk. But just to say that using the short-term dynamic model, there's evidence that it outperforms supportive therapies and CBT in reducing anxiety in major depression. And also in a new meta-analysis we're doing, it outperforms CBT for somatic symptom disorders. And the finding is an overall large finding, but it marginally fails to reach significance in when you remove one study. So there's a signal that emotion processing helps with these patients may be more helpful than some other processes. But overall, doing these things reduces relapse risk. Sociofamilial group can definitely benefit from support, encouraging social structures of different types, groups, family interventions, education. And the severe fragility is really similar, but benzodiazepines are contraindicated here. They can make things worse. Antidepressants can make agitation. And it can make more nightmares. They can make them have more projection. So they can get more scared when you give an antidepressant. If you give an antipsychotic, they can get more depressed. It can cause more repression. And then stimulants can be of assistance here, but again, you're not going to be able to stop them. So what happens when we see these individuals is they come on 4 medications. They come on benzos, antidepressants, antipsychotics, and mood stabilizers, sometimes stimulants. So recognizing that there's an attachment emotion process in the picture, trying to address it, we can avoid some of the adverse components here. But again, there needs to be enough therapist hours available to provide ready treatment. Ideally, by the way, in early life, if you see already that an infant or a child's having an attachment disorder, what about treating the parents or trying to work with the children as early as possible to spare them 50 and 60 and 70 years, like we're seeing people 60 and 70 years of unaddressed attachment trauma. So it's the same, more or less the same thing with the severe fragility. There are treatment models. They tend to be longer. As I mentioned, a couple of years. Transference-focused psychotherapy, mentalization-based therapy, DBT, the treatment we use here. Building capacities to tolerate anxiety. And then the emotion starts to break through. We need to be very comfortable with heavy, strong emotions ourselves. We have to be able to tolerate our own anxiety. It's more of a challenge for us. I recommend people working with these individuals work on teams. They have peer support and have a colleague to give them a hand around these cases, so you share the process with somebody, not working in isolation. And then you have to address feelings about endings. So if you don't address the feelings about endings, the patient can't terminate or they regress when you're trying to end treatment. And how often does this happen? It's the same concept when you reduce medications and try to stop treatment. They can regress because of the emotional component involved with that, as well as sometimes you could say it's a biological process of when termination is happening too. Obviously, these are both happening at once. So they can do well with long-term consistent supportive structures. Risk management is something to know about here. Really, generally don't know how to handle regressions. Avoid too many therapists in one picture as much as possible. So that's like a 3-pager on these things. So again, if we take these sort of big 3 groups, psychotic disordered individuals can also have attachment patterns across here. So can bipolar patients. So can severely depressed patients. And on top of that, every other major psychiatric disorder can have all these patterns as well. So you can see all these patterns except for low resistant with eating disorders. I haven't seen a low resistant patient with eating disorder. ADHD, substance use, anxiety disorder, somatic symptom disorders across these spectra. And what I'm saying is to consider the psychophysiologic patterns in your biopsychosocial management rather than thinking, okay, I'm going to treat this as this condition, but consider these parameters here. Here's just our treatment-resistant depression study that we've just published 2 years ago, and we're publishing the follow-up data soon. And just to tell you where, for example, these patients are. We had no low resistant, we had 1 moderate resistant, 3 high resistant, and the bulk were here, fragile and with repression. So these are more your bona fide traditional severe major depression pattern of this exhausted, repressed pattern. So most of them had a bona fide depressive process not responding to meds. And in treatment, 90% are personality disorder, 90% are chronic medical illness. This is a very ill population. They had 16 sessions with us. Most reduced or stopped meds. And in community mental health treatment, most had increased their meds or kept on their meds, and most had CBT. of one type or other, individual or group. And here's what we found in the 6-month follow-up, that the community mental health team service on Hamilton Depression Scale, 3.7% remitted. That's one patient referred out of the 30 remitted fully on the HAM-D. In our treatment arm, 36% remitted on the HAM-D. And for people that know the literature, this is a high remission rate. And the follow-up figure is 40% remission on HAM-D, which is as high a figure as we've seen in any outcome study for treatment-resistant depression. And that's with 16 sessions. And again, it's mostly a fragile group who should have more than 16 sessions in the real world. They would have a year. With a year of treatment, we would theorize or hypothesize or would love to test someday, what percent of these people could actually remit? Would it be 2/3? Here, the other issue here is all this chronic medical illness was there, and this obviously has an effect. And the personality dysfunction was quite prominent as well. So it was like doing part of the work to do a study. Now, when you use this model, adding it on to patients with psychotic disorders, and a lot of these were referred in collaboration with Lily Kapala back in the early 2000s. Here's what we found. First, that they had 13 sessions average. Paranoid ideation was cut in half to the normal range. This is self-report paranoid ideation on the brief symptom inventory. Interpersonal gains, with a modest effect, were significantly improved. But this is the hospital use went down to normal in the on up to 4-year follow-up. Physician use went abruptly to normal and persisted in follow-up. So their use in relating to the healthcare system diminished significantly. And that's as an adjunct to existing care for psychotic disorders. And this is with the same type of data with bipolar disorder. There's 29 patients at 4.6 sessions. This was, again, so some of this was done in conjunction with Vivek Kusamaker back when he was here. And the depression scores were halved after the first session. So it's an abrupt antidepressant effect from this treatment approach with bipolar patients who have some depressive features. Their symptom reduction was a large effect of symptom reduction, a large effect of interpersonal gains. And again, this is their total hospital and doctor costs going down here into the normal range in follow-up. Using it as an adjunct on inpatients for psychiatry, 9 sessions, 32% of all the inpatients were referred, a third of them basically. They had all these conditions here. So again, this is an adjunct. This isn't the whole treatment. This is helping the person deal with their attachment-related problems. Symptoms reduced significantly. Interpersonal problems reduced the same kind of modest size. Almost a 2/3 drop in ECT use on that ward, such that the cost was recovered by not having to use ECT as much, paid for the psychologist that was working on the ward. 52% fewer people had ECTs in that follow-up interval of 18 months. And there was a 23% drop in length of stay. This is a brand new study we just published, so I don't have all the details on it yet, but it's this is with substance addiction, using this approach that we use here for substance-dependent population. So a fifth of these people had a psychotic disorder, 21%. 25% had antisocial personality disorder. It's a very tough population. And 23% dropout only, which I'm told is quite low. And they had an almost 50% sobriety rate at 6-month follow-up, which I'm told is quite high. And it was in comparison with bona fide good standard drug counseling treatment for the same population. So they had a lot more dropout and a lot less response, sobriety at 6-month follow-up. So that's being replicated now in another center in the States. So just encourage you to think about this here, about evaluating these parameters and sort of as an adjunct into a standard assessment about how the downstream effects of attachment trauma impact on physiology, and then overlay or directly impact or directly are the presentation. of a mental illness presentation. Treating these trauma can reduce adverse effects and hospitalization and relapse risks, and on its own can be curative of the problem depending on what it all is. And treating the attachment trauma over outcomes improves outcomes over therapies that don't tend to purposefully address attachment trauma. So adding in this component of observing unconscious emotional processes appears to add something on. The other is just to say that, a lot of these patients obviously present to medicine, surgery, emergency. Some get surgeries and procedures. And to me, it's like it behooves us as psychiatrists to be the profession that understands psyche and soma. Basically, that we can educate our medical colleagues and support them to understand what's happening when they're interviewing their patients and to help them reduce adverse effects of procedures and medications. So those are some of my comments. I guess we have quite a bit of time for questions, so go right ahead with questions. Larry's here too.
Thank you very much, Allan, and thank you for being such an adaptable presenter. So we can see if people want to type questions into the question box up there. Joanne says, still trying to connect. Okay, so I actually have a brief tutorial because I was trying to use my computer in the Abbey Lane in my office here. And if you have one of these, or if you don't have one of these, hard to hear me. Okay, all right. So just a comment for those people online who still might be struggling with this. Although if you're online, you may not be struggling with this. But if you need one of these, so my computer out at Cobequid, I know that they've bought a bunch of these sort of speaker devices for us so that we can use Skype for Business, because again, this is what the health authority wants us to use, is Skype for Business. Some people seem to be able to just use headphones with a mic, but when I tried that in my office here this morning, that didn't work, so I had to borrow this from one of the people on the 8th floor. So just a little aside, as people are thinking of questions they might want to ask Dr. Abbass about his excellent presentation, if you talk to your manager, you may be able to get one of these. So any questions regarding Dr. Abbass's presentation? So maybe I'll just make a comment, Allan, that I really enjoyed your presentation, and I trained with you as a resident, of course, many years ago. And I wonder if you have any thoughts about how someone like myself, who doesn't really do much actual psychotherapy in the clinic, how I can incorporate some of the principles and understanding of these processes into my psychiatric care of patients aside from psychotherapy.
Yeah. So one thing is that it doesn't require to be sort of doing a whole treatment course to evaluate the person's physiologic response. To the person's whole physiologic responses. Just adding it into your mental status examination will often assist the patient to recognize something that's going on that they weren't observing, mainly their nonverbal cues, that when they talked about the fact that their mother died and they get nauseated, that helps them understand that their body's responding to emotions. And you can just weave that into your feedback and your formulation with the patient. This on its own seems to help them. So when we've trained, for example, the emergency physicians to do some of this in their assessments, and these are people with chest pain and abdominal pain and headaches, we see that those patients on their own have a significant reduction in emergency use. Before they even get to us, they improve. Because just understanding it is helpful on its own. And for us to understand it, it may say, well, look, if I'm thinking here, which medication am I thinking about here? Or is it worth referring them or trying 2 sessions of something? I'm talking 2 sessions of CBT, to even give them a book at home to read, send them an app, something to try to settle their autonomic nervous system down. For example, or have a handful of meetings, or have somewhere to refer. So it might inform trying on something on a psychotherapeutic level, or some other level, or some other behavioral intervention. Just recognizing that this is a component that also may impact long-term care. So if you see a person who's really stuck and difficult and distancing and very harsh on themselves, that's going to override the care of their prominent primary mental illness, so how can they get some help for that part, and to reduce their risk of relapse and to improve their quality of life, even, while you manage whatever else they have to deal with on their health or mental illness side. So you can incorporate elements of it, just the observing component, just some feedback for the patient, and that can be helpful on its own. How many hours? So someone asked,
how many hours of training would it take to train an entry-level clinician to be able to do ISTDP with patients with severe attachment trauma fragility?
Okay, so thanks, Jason. So here's the thing with that is that some people already are working with those patients now, doing something, and doing a process of reflecting. So what it would be in some cases is a refinement or assistance on some monitoring tools and specific type of augmentations that we could help with on stuck points or points where they find there's certain challenges that may relate to the kind of parameters that I'm talking about here. For example, termination problems. For example, tending to regress when they feel a little better. For example, reacting when they start to like the therapist. These kind of attachment processes, you can really use that to augment existing cognitive therapy skills, IPT skills. So some people already have skills and experience, and that's huge with this populations. If you want to say a new clinician starting off, it's really variable too as to how long it takes to train. But an average person, if they have 2 years of case review, can work comfortably with like a quarter of the population, which is tons of psychiatric patients that are referred. So that's an average person. Some people can work way more than that. And some people struggle a little more because of their own anxiety intolerances, for example, or difficulty recognizing their own emotions. So if there's more of those kind of problems, it takes a little longer to build the skill set. So it's partly individual, previously skilled based, but there's certain augmentations that definitely can help with people who are already working with the populations.
Yeah, so I guess just thinking about that myself, I saw a patient last week for a quote-unquote med consult who had actually been seen by geriatric medicine about possible memory problems, doesn't have a memory problem, doesn't have dementia, young, 50-something person who has anxiety and cognitive disruption that you could even see in the session and so on. But it is hard to know how to approach that sometimes when you're seeing someone for quote-unquote a med consult. I kind of brought it to his attention and said, well, I think that's anxiety, but I don't know, should we pursue it further, or what would your thought be about that?
Yeah, so oftentimes, like a person referred to us, for example, for deep brain stimulation for tremor. They come in and they're not aware that they're so tense in their body and so tightened up, they're not even conscious of that at all. So they're coming in to say, is there something that can help me psychologically, in any way? Can you help me with this tremor problem? But they don't notice that their body is working that way. Now, when you help them notice it, they're often annoyed about it, but they really appreciate it too. So when they have that experience of those mixed feelings with us, it brings up some of those attachment feelings. So later in the interview, now they're talking about their childhood experiences and they have some grief. They go out and they're calmer and they're less tense and the tremor is reduced. So sometimes just weaving it into a regular consultation and say, so why does your body do that anxiety? Why do you get that cloudiness? What's that about? And bringing curiosity into it, just like as a concerned person, it helps at least initiate a process for some of them. For some, it helps them a lot as far as symptom reduction. So it's some things you can bring in and augment what you're already doing, because intuitively right? You said, I know there's something going on here. And then you want to raise that with the patient and then watch how they respond to it. And then when you do your summing up, you can say, so there's 2 parts or 3 things going on here, but one seems to be that you get quite anxious when you sit with a doctor and it affects your vision, it gets you cloudy. I wonder if that's something you'd like to meet with someone about. So it can help on referral at the end of a consult. It can make it natural to work with a therapist from your practice if you don't have ability or time to do therapy yourself. So it makes it smooth referrals to start that in the conversation. Same for doctors. If they can raise that in a medical assessment, it makes it really easy to make a referral.